Good afternoon. So now we will speak about laser-assisted drug delivery, and I'm very pleased to welcome Professor Merete Haedersdal from Denmark, who is very well known in France and who has a huge experience about a lot of topics, and especially the laser drug delivery system. And Anne Le Pillouer-Prost, also very famous, and we have also a lot of experience. I'm very happy to be able to discuss with them, because I think it's really a new device, a new kind of treatment, and probably a lot of future for us. So first, my question is, we know the laser drug delivery system, and what do you think about really the interest in dermatology? I mean, not only on a theoretical point of view, but also regarding the practical consideration. You think it's really very interesting for us, why and how to use it? I mean, which drugs, which devices, and which indication?
Yeah, so first of all, thank you for having me here. We have been working on laser-assisted drug delivery for almost 10 years in a collaboration with Copenhagen University and Wilman Center of Photomedicine. And when we started out, we looked into the basics, and it's now flying high. We have learned a lot about the basics, and it's now taken into clinics. So the first thing we were considering about is about the laser itself, how to tune in the laser. If you want to do drug delivery, how should you tune in the laser? And there we have learned that there are three parameters with a laser that you are tuning in when you're using laser practice for drug delivery. First of all is the number of holes with fractional lasers, the number of holes per centimeter square, and also the pulse energy, which means that how deep do you want to drill the holes. And then also the tiny little coagulation zone around the holes, is that an advantage or a disadvantage? So if I should put in a nutshell the research we've done over 10 years, I would say in terms of the basics, tune in your laser density to low laser density settings, 5, maybe 10% coverage. But I don't know, Anne, is that also what you are doing in a clinical practice? Do you agree with me?
Yes, I totally agree.
Yeah, and then the next parameter was pulse energy, or the depth of the holes. There we have learned that it depends on the drug. If you are using a hydrophilic drug, you can take advantage of deep holes. But if it's a lipophilic drug, then you cannot, to the same extent, take advantage of drilling deep holes. So what I do with this theoretical background, taking into clinics, is that I look at the clinical indication. If I'm treating a very thin pre-malignant lesion on a fragile chest area, then I only use very superficial pulse energies, drilling very superficial holes. But if I'm treating a very thick hypertrophic scar, then I estimate the depth of the scar, and I tune in the pulse energies or the depths of the holes to match the thickness of the lesion. Mm-hmm. What about you, Anne?
Yes, it's very interesting. And for nail, I think it's the same things. You have to adapt your settings to the area of the body, the indication, the gender, the age, and the molecules, the charge, and so on. Yes. And for nail, for example, what would be your recommended parameters?
I'm a beginner in the field of laser-assisted drug delivery for nails, or I think the entire field is just in the very beginning. But what we are working on in the lab back home in Copenhagen is that we are doing imaging to look at the laser nail tissue interactions.
Yes.
And what we have learned so far, we're looking with OCT scans. And what we have learned is that the uptake of the laser energy is different from the skin, which is not a big surprise, since there's not so much water content in the nail, and we are using wavelengths that do absorb energy from water. But a typical setting I would use is for a normal thickness nail would be 40 millijoules per microbeam. How does that sound to you from a clinical setting?
I choose 300 millijoule.
Wow, doesn't it
yes.
hurt?
Yes, with stacking and a lot of
Yeah, but
energy.
maybe if you are having a thick, maybe
It's
mitotic nail.
In daily practice, is for fungus onychomycosis. So often nail are.
You are tough in France. The Danes, they would scream. That's a lot. But maybe it also maybe due to different devices we are using.
Yes.
Maybe there is the explanation.
And in PDT indications, for example, for thin actinic keratosis, I think you are using 10 millijoules, 5% density. But for BCC, for example,
Yeah, there I think it's important to realize that for basal cell carcinomas, we have to be careful when we are treating nodular basal cell carcinomas. At least when it's high risk nodular basal cell carcinomas, it's not approved indication. But if we are treating superficial basal cell carcinomas or small nodular basal cell carcinomas, I again adjust the depth of the tumor to the settings. And there, typically, if I have a small nodular basal cell, I would use maybe 40 millijoules with pulse stacking, two or three stacks, summing up the pulse energy, but depends again on the anatomical location.
okay.